Hello, let's continue with our session on carbapenem. Let us learn how to diagnose. What are the criteria defining carbapenem resistance? Detection of carbapenem producing isolates in clinical specimen is first based on a careful analysis of susceptibility pattern. Recently, both the CLS and the UCAS breakpoint for carbapenems have been lowered significantly to allow better detection of carbapenem resistant isolates. Screening cutoff values for the carbapenem producer are advocated by UCAS and Medopeda has been proposed as the indicator antibiotic with the best sensitivity or specificity ratio. The breakpoint cutoff by UCAS for minimum meropenem for detection of the carbapenem is more than 0.12. The resistant breakpoint is 8, sensitive breakpoint is 2 as per UCAS. For CLS it is 4 and 1 respectively, but for the screening cutoff for carbapenem it is more than 0.12. Why search for carbapenem activity rather than carbapenem resistance? The reasons for detecting carbapenem genes are multiple, as they are mostly plasmid borne, particularly in Enterobacter. They spread easily. All three main types of carbapenem genes, such as BLA-KPC, BLA-NDM, and BLA-OXA, have the ability to spread within Enterobacter species. The BLA-KPC and BLA-NDM genes have been identified in Enterobacter, Pseudomonas and Acinetobacter, showing their ability to cross the species barrier. Carbapenem producers are also associated with other structurally unrelated resistance traits. Therefore, identification of this multi or even pan-drug resistant strains is important to prevent their spread and to guide the antibiotic therapy. Now, how to detect carbapenem producers as infectious agents? Any suspicion of carbapenem activity should be based on analysis of antibiotic susceptibility results. In a clinical lab, detection of carbapenem activity on cultured isolates can be performed by mass spectrometry, that is MALDI-TOF technology, that is matrix associated laser diffusion ionization time of flight mass spectrometry technology, which gives results within 4 to 5 hours. The detection of carbapenem activity is based on determining the modified spectrum of a carbapenem following contact with a lysate of the bacterial culture. This technique requires the development and validation of specific protocol, a period of incubation time of about 3 to 5 hours, additional centrifugation steps, a MALDI-TOF instrument, and a trained personnel. Rapid colorimetric detection of a pH change of half to 1.5 hours is another test, which is based on detection of hydrolysis of beta-lactam ring of carbapenem molecule, that is imipena. Hydrolysis acidifies the medium, changing the color of the pH indicator, which is phenol red. No reading device is required. The result can be read directly on the test. Both of these methods are highly sensitive and specific, and both detect carbapenem hydrolysis, but not a specific and limited number of resistance genes are detected. They can detect any type of carbapenem activity, including activity resulting from the spread and expression of novel carbapenem genes, and results are available rapidly. These techniques detect carbapenemase activity in Enterobacter, Pseudomonas aeruginosa, and Acinetobacter bowman. The presence of colorimetric detection of carbapenem activity is depicted from this figure. How to identify the carbapenem of the exact carbon time is currently required in two clinical situations. One is during an outbreak and another for epidemiological purposes. During an outbreak, it is required to screen the contact patients, close to the source patient, and to rapidly identify the carriers. And for epidemiological purposes, it is required to monitor the spread of the carbapenem producers at local, national, and now what are the phenotype of detection of specific carbapenemas? One is KPC, where boronic-based inhibition of KPC activities is reliable, at least with Klebsiella pneumonia. And when KPC is the only carbapenem produced in clinical isolate. MBL, the detection of MBL activity is based on inhibition by MBL inhibitors such as EDTA, dipiclonic acid, penethrolone, mercaptonic acid, and mercaptoacetic acid. This chelates inactivate MBLs by depriving them of the zinc ions. Phenotypic detection of the MBLs is reliable only when dealing with Enterobacter and Pseudomonas, but not with Acinetobacter bowmani, which gives false results. Oxocyrinase, none of the above mentioned tests can detect oxa carbapenemase in Enterobacter, or in Acinetobacter bowmani, since the enzymatic activity of oxa is not inhibited by clavulanic acid, tazobactam, sulbactam, or zinc chelators. So high level resistance to temocillin and peptides in Enterobacter, exhibiting resistance or reduced susceptibility to carbapenem may be predictive of oxa 48 carbapenemase. What is the molecular characterization of carbapenemase? Molecular techniques are mainly based on PCR technology and may be followed by sequencing of the entire coding region. PCR-based methods include simplex, multiplex, and real-time assays. Hybridization and microarrays can be used. The results of the molecular-based techniques are highly reliable. Several molecular techniques may be used directly on the clinical samples such as feces, Although correlation between the molecular identification gene and carbapenemase expression in clinically relevant bacterial species has not been assessed. The main disadvantages of molecular techniques as screening techniques are the cost, equipment cost, and for some techniques, trained microbiologists are required. Therefore, the use of molecular-based screening as a first-line approach may be currently limited to identification of carriers in outbreaks or for epidemiological purposes. So, the current picture shows the strategy for detecting carriers of carbapenem producers based on detection of the resistant genes and based on conformation phenotype, genotyping, and anti-susceptibility testing. There are also rapid diagnostics available or multitude of which is available for detection of carbapenemase producer and non-carbapenemase producers. Which patients should be screened for carbapenemase producer? Detection of carriers is mandatory since they represent the reservoirs for the further spread of carbapenemase producers. The recommendation have been proposed for screening in during an outbreak situation. Patients in contact with index patients should be screened. In many cases, this screening includes at least all patients hospitalized, patients transferred from any foreign country, or patients hospitalized abroad within the year prior to hospitalization in the present country. So, depending upon the prevalence of the carbapenemase producers in a country, regular screening of high-risk patients such as those hospitalized in ICU, transplants, immunosuppressed can be recommended. Screening of carbapenemase producers in Pseudomonas and Acinetobacter should include at least those patients hospitalized in the same hospitalization when the outbreak is occurring. Screening of non-carbapenemase related to carbapenemase, there is here no specific recommendations are known. Patients who are at risk, the screening is justified only for contact patient in case of outbreak, patient directly transferred from any foreign material hospital, and then patient hospitalized abroad within the year prior to hospital admission. How to screen these carriers of carbapenem gram-lactobacilli? Since the intestinal flora is the main reservoir, rectal swabs and stools are the most commonly used clinical samples for screening of carbapenem producers and carbapenem resistant isolates. In the case of Pseudomonas, environmental screening may be useful since waterborne outbreaks have been identified because of carbapenem producing Pseudomonas. In case of Acinetobacter, skin or nasal swab samples may be used for detection of carbapenem isolates. That was about the detection of the carbapenemase. How to Four preventive measures are based on standard precautions such as hand hygiene as well as contact precautions that apply to any multi-organism bacteria. The implementation of screening and isolation is more effective if the diagnosis of colonization is made. Currently, CDC recommendations for preventing carbapenem production in healthcare facilities have been published drawn from the experience of KPC producing KPC outbreaks in Enterobacter. This recommendation may also apply for the prevention of NDM or oxalate producers. Now, contact precautions aim to prevent the transmission by minimizing the contamination of the healthcare professionals in contact with the patients or the environment. Adherence to contact precautions required appropriate use of gown and gloves by the healthcare professionals, isolation of the carrier patients in single patient rooms, and individual patient use of non-critical medical equipment or disposable medical items. In both the acute and long-term facilities, to facilitate the prompt implementation of the contact precautions, computerized surveillance should be placed in place to identify the patient with history of colonization or infection by carbapenemase producer. In addition to placing carbapenemase producer colonized or infected patient in single patient rooms, cohorting the patients together in the same ward should be considered. If feasible, there should be dedicated staff to exclusively care for patients with carbapenemase producers and therefore maximize the risk of transmission. Role of fluorescent bathing to interrupt transmission of carbapenem producers is not well established. Similarly, decontamination to growth flora remains highly debatable. The 6 core measures for the prevention of carbapenem resistant enterobacter include hand hygiene, then contact precautions, patient and staff cohorting, minimize the use of invasive devices, promote antimicrobial stewardship, and screening. The take-home message is take into account the size of the reservoir of carbapenem-resistant bacteria under worldwide location. Reversion of the carbapenem resistance to susceptible isolates will not occur at least in Enterobacter. It is therefore essential to screen both the carriers and infected patients with carbapenem-resistant bacteria. This is the only way to preserve the efficacy of the last resistant antibiotics, carbapenems, and the only option while waiting for novel marketed broad-spectrum antibiotics. That's all. Thanks a lot.